Hi guys, welcome back to BROMED Lectures. This video is going to focus on the part 2 of the Diabetes Mellitus series. We're going to cover management and health goals for these patients. So let's begin with management for these patients. Remember, these are chronic condition patients and you're going to be assessing them for long periods of time. So you have to keep in mind these three objectives, which are controlling symptoms, preventing acute decompensation, and limiting long-term complications throughout all the evaluation of these patients. And these are the three things that you want to achieve with them. Now, for the first-line treatment, people always mention metformin and lowering blood glucose, but the real thing here is that this is the first line therapy for everyone. It is patient education. This is the one that's going to make all the difference for these patients. Now, you also want to promote weight loss, blood glucose monitoring, the implementation of certain diets, starting the patient to perform exercise, and of course, eventually you will add drugs, but you also want to monitor long-term complications for these patients. But remember that educating the patient and lifestyle changes are going to make a great difference over time. Now, for the health goals of these patients, there are 6 different goals that you have to keep in mind for the evaluation of these patients. And now, glycemic control is going to be the first one, and this one is measured with hemoglobin A1C, and you want to measure this level at least every 3 months, okay? So the goal right now set is 7 to 8%. It was usually mentioned as less than 7, but we have seen better outcomes with patients controlled into 7 to 8% concentrations of hemoglobin. So we're going to develop another video that is going to be a pro series for these recommendations, and we're going to state why it is unnecessary to put patients at levels below 7 and why it is sometimes useful to put patients at levels below, higher than 8. And now with the screening, we have, of course, these 2 parameters. The first one, lipids. You want to diagnose dyslipidemia as soon as they appear. And of course, measure blood pressure for identifying hypertension if it develops, since these both are going to increase your cardiovascular risk. Now, for the cardiovascular risk health goals, of course, you want to implement diets to promote weight loss, exercise, and smoking cessation. But consider that if the 10-year mortality risk for your patient is already higher than 10%, then you should assess if aspirin is needed. Most of the times, it is going to be aspirin what you need to add to these patients. For nephropathy, you want to perform an albumin-creatinine ratio, and this one is performed annually. But remember that for type 2 diabetes, it is performed at diagnosis. And this is because usually these patients already have diabetes going on for many years, and now you can evaluate what is the extent of the damage in the kidney already. And for type 1 diabetes mellitus, it is usually assessed starting 5 years after diagnosis, since it is the time when we start seeing the nephropathy in these patients. Now, for retinopathy, we usually perform ophthalmologic evaluation, and it is usually performed annually. And this one includes slit lamp evaluation in order for you to assess the retina. For neuropathy, what you do is implement daily care, educating the patient to perform daily care in order for them to care for their extremities. And of course, you screen with annual foot exam. And when they have already developed the disease, daily care is going to be what is going to prevent the acute complications of neuropathy. So let's move on with the specifics of the management. In this section, we're going to cover the drugs, its mechanisms of action, the benefits, and of course, adverse effects and some other considerations that you need to have for these medications. The first one's going to be insulin. This is the direct replacement of the hormone. And of course, we have developed different formulations in order for we to keep direct and strict management of the blood glucose levels of the patients. We have short, rapid, intermediate, and long preparations, and we usually use the intermediate and long preparations in order for the patient to keep a basal concentration of insulin. And the short and rapid are usually used during meals in order to avoid peaks during these episodes. Now, the benefits is that as it is the hormone, patients are better controlled with this medication. The adverse effects, it's of course hypoglycemia. If the patient has daily habit changes such as strenuous exercise, skipping meals, or whatever, and they do not perform a strict insulin dose adjustment, then they can develop hypoglycemia. Of course, lipodystrophy and hypersensitivity reactions are usually developed at the sites of injection. And remember that this medication is usually metabolized by the kidneys, and so you have to adjust those if the patient has advanced chronic kidney disease. Now, with metformin, this is the first line therapy for patients with type 2 diabetes mellitus for so many reasons. It lowers the hepatic gluconeogenesis in order for the patient to avoid hyperglycemia. And so the benefits is that it promotes weight loss in patients. It is cheap, it does not promote hypoglycemia episodes, and it is usually pretty safe to use. And now for the adverse effects with metformin, the most common one is going to be GI upset. Patients report nausea, vomiting, diarrhea, and it commonly wanes off over a few weeks. So encourage patients to keep with the medication as long as it is not super bothering or devastating for the patient. Now, it is associated with lactic acidosis episodes. So any patient that has a previous history of lactic acidosis or some predisposing condition for lactic acidosis should avoid the medication. Have caution with patients with renal failure, congestive heart failure, liver disease, and surgery, because lactic acidosis is where it commonly appears with these patients. And now with sulfonylureas, they act by increasing the insulin release, and they do so by blocking the potassium channel at the beta cells and promoting cell depolarization and secretion of insulin from the vesicles. Their benefits, of course, it is also a cheap medication. It is usually added after metformin or in conjunction with metformin. And the adverse effects, the most common one is going to be hypoglycemia because it increases the insulin release. And for the first generation, not commonly used nowadays, the sulfurium-like reactions, and for the second generation, only the hypoglycemia, they all promote weight gain with the insulin release. Let's move on to the last medications. We have the glitazones or thiazolidinediones, which act through the binding of the PPR gamma receptor inside cells, and they promote insulin sensitivity. The benefits is that they're usually recognized as second-line medications. They can be added after metformin or concomitantly with metformin, and you're avoiding the risks with sulfonylureas, that is hypoglycemia. Now, the drawbacks is that this usually cause water retention and promote edema, and you should avoid them if the patient has congestive heart failure. They also promote, because of the insulin sensitivity, increased weight gain. So keep that in mind for these patients. The sodium glucose cotransporter 2 inhibitors, they block the reabsorption of glucose in the proximal tubule in the kidneys. They promote weight loss by this mechanism, but they also lower the cardiovascular morbidity and mortality. And this is important because we're changing our health goals towards cardiovascular morbidity and mortality, and not only to hemoglobin A1C or glycated hemoglobin concentrations in the patients. Now, the drawback is that this action depends strictly on the glomerular filtration rate, and if the patient already has chronic kidney disease, you're not going to see the results as in a healthy patient. Glucosuria is promoted by this medication. It increases UTIs and vaginal infections. And so if a patient has these conditions or has some predisposition for these conditions, you should avoid this medication. And also keep in mind that this medication may cause dehydration. The alpha-glucosidase inhibitors, these ones lower the glucose digestion and absorption, and by this mechanism they promote weight loss. But they also promote GI upset, and so these medications are nowadays rarely used. The GLP-1 analogs, they have many mechanisms of action. They lower the glucagon release. This decreases glucose in blood. They also promote a lower gastric emptying, and with this patients see increased early satiety, and that is good because the patients will report that they are eating less, and that is going to promote, of course, weight loss. And this medication also by hormonal mechanisms increases insulin release from the pancreas, and that is going to avoid hyperglycemia in patients. This medication, due to the weight loss and the other mechanisms of action, also has shown decreased cardiovascular morbidity and mortality. And remember, this is where we're leading towards our health parameters in diabetic patients. The drawback is that these medications are, for the most part, injectable, although there are novel oral medications out on the market and being approved recently. And they are more expensive than the other medications we have already mentioned. They can also cause GI upset because of the early satiety and have been associated with pancreatitis. And now the DPP-4 inhibitors, what they do is they increase the effect of the GLP-1, the endogenous GLP-1, and they do so by this mechanism. The DPP-4 inhibitors, they are going to inhibit DPP-4, right? And so DPP-4 normally deactivates GLP-1. So by inhibiting the DPP-4, you're increasing the GLP-1 concentrations in your patient. And so it is going to have similar effects to the GLP-1 analogs, but it's not going to promote other better mechanisms of action, such as the early satiety. And so that's why you are not seeing weight loss in this medication, although they also increase insulin release because of the GLP-1 and are considered weight neutral medications.